the first bit of the celebrations that we kick in today for the Society of Fetal Medicine. We are 10 years old now, and or should I say 10 years young. And I'm truly looking forward to an exciting program with Ravi Chawi. You know, he was voted our most favorite speaker in India consecutively for the last 9 years. And I'm really looking forward to his talk today. But before that, let me take this chance to thank viewers we have today, not only from all over India, but a large number from the Russian Federation. We have invitees from Israel who are here. We have a lot of people who've come in from Turkey. We also have Afghanistan, surprisingly, which I hope is a good sign. We have Pakistan and Bangladesh. We have Sri Lanka, the Maldives. And when I'm looking down the list, it's really marvelous. It's all the way up to Korea and all the way down to Bali, Indonesia. And it's a real pleasure to be here for this, should I call it an anniversary celebration? Should I call it a Foundation Day celebration of the Society of Fetal Medicine? Or should I just call it a birthday party? Because I think it's the most fantastic. I will share with you a bit, which will take you very briefly through. I promise I won't make it very long, because I know everybody's just wanting to listen to Ravi right away. But I really wanted to bring to you this photograph from 2011. We had our first international congress on October 1st and 2nd, 2011 in New Delhi. And we were extremely impressed with ourselves because we had Ravi Chawi, who specially came in. He'd been encouraging me for several years to do this. And this is a photograph from 2011. And I found it on Facebook a few days ago. And I said, wow, it's so nice to see that when you're in association with the Society of Fetal Medicine, you start looking younger with every passing year. We had an excellent meeting. We spoke that day on the intracranial translucency, and we already realized that it's a 6-year-old description. He had first described it in 2005. We had Dr. I.C. Verma as our founder president. You know how the Society of Fetal Medicine started, and for those of you who do not, we were actually a part of another society, which was a Society for Prenatal Diagnosis and Therapy. And then the Delhi unit of that society was 6 times the size of the All India unit. And we said, now what do we do? So we said, okay, make us big because we are the biggest, and everybody ignored us. And we said, now what do we do? So Professor I.C. Verma said, it's time to grow up. Let's have our own meeting. Let's have our own society, because we seem to be bigger than all the parent societies. And that's how the Society of Fetal Medicine began to give each one of us an opportunity of not being sidelined, to give each one of us an opportunity to rise, to interact with marvelous names like Ravi Chawi, who have supported us throughout over these last 10 years. And of course, to get the guidance of stalwarts like Professor I.C. Verma, who continues to be the founding editor of our Journal of Fetal Medicine, as well as the founding president of the Society of Fetal Medicine. That meeting was a big meeting. And we had over 600 attendees. And in this photograph, see Professor Sneh Bhargav, who was the first to say that ultrasound belongs to everybody. She firmly believed that for ultrasound to survive, we had to make sure that everybody should be able to do good ultrasound scan and not let the technique get a bad name. And I said, well, excellent. And that's where we started off. She was waiting for us to bring in a little footstool so that she could stand on it. We couldn't find one in the hotel, so we let her stand behind the podium where we couldn't see her. We learned over the years that, yes, some of our attendees and some of our friends will require that. We also had that day with us Dr. Kamal Bakshi, who was the founder of many techniques of fetal medicine in India, and is an active member with us today and has some excellent scholarships and orations to her name today. We went on, the inspiration actually came from this. This was a course we did in 2015, and it was the first meeting that I had with Ravi Chawi, and he said, of course you can learn, this is not difficult, you can do it. And I said, nah, I can't do this. Then I said, the machine is too expensive. He says, no, get going. And that's where the whole story started. And he says, no, you come and we will do this. And I said, well, I'm not sure I can come. He says, then I will come. This was 2 weeks after we'd had the massive floods in Mumbai in 2005. And we had to change the date of the meeting because there was ongoing floods in Mumbai. He says, okay, what do we do? I said, well, come to Bangalore if you can. And he came to Bangalore, and he canceled the other weekend that he had somewhere else in Europe. And he says, okay, instead of Mumbai, I'll come to Bangalore. And this is a picture there from that meeting. I got certified as someone who can do ultrasound, and I was just so pleased. This is the only photograph I have of anybody in my clinic. And everyone says, who is this man? I said, he's the one who's written those wonderful books. And then I tell them the name. They said, oh, he looks much older then. Thank you so much for getting things going then, Ravi. It was really, really absolutely charming. I relish this photograph. It's the basis of my existence today. And then, of course, you agreed to even give us a live demonstration. And you can see there's Bernard Benoit in the background. In that same meeting in 2011, it was a very well-received meeting. It was on the day of the workshop, we actually had 900 participants. We were able to divide the costs that way. And Bernard Benoit gave us some excellent insights. Ravi was there giving us 4 hours of live demonstration. The crowd didn't want to go away. We got thrown out of the hotel room at 8 p.m. They said, look, we need this room for another meeting. And I said, okay, then we'll give up. And that's how we had our very first successful meeting. We've never, ever looked back. And it was so wonderful because Ravi is so good at giving to everyone. Here he is with all the delegates just getting their copy of the second edition of his book signed. And it was absolutely fantastic. I think that's the third edition. Yes, that's the third edition. And willing to pose for photographs with everybody. And you can see there is people here who've grown up ever since then. And we have Vimala, our president from next year onwards for 2 years, standing right there next to Ravi. And it's so nice to be able to pass on the baton to him to handle the Society of Field Medicine from next year onwards. As you can see, Bernard Benoit has been a great friend and supporter, and he's promised to actually do programs for us in the coming year as well. He's now re-established in terms of what he's going to be practicing and how much relaxation he's going to give himself. But it's really going to be very nice that we're going to be able to achieve so much more together in the coming year in terms of our training. And COVID has had this one advantage, that it's opened up the virtual world. We've also understood that we can run workshops and have a much better communication when we're all together, and and we can have smaller and more frequent workshops. And now that we're all in a better financial position, we can actually afford some of this activity. And then again, to show how wonderful it is to be able to share. And that was our registration desk at that time. And everybody waiting patiently for their certification. And you can see someone was trying to find the receipt on whether Ravi Chavi had paid his money or not. It was the joke then. And this was a few years later, we'd started with the tradition of CardioCon. And this was our CardioCon we had in 2017. And absolutely fantastic guidance on how to do a scan, how to look for abnormalities. Everybody said he's going to speak for 17 hours in 2 days. I said, yes, it's actually 19 hours in 2 days. It was at that time also an ISWAC recognized program. So we had a huge international presence. And as usual, we ran out of space. And we had 600 registrations come in the last 1 week, and we didn't know what to do. So we just picked up another hall behind it. It was a narrower hall, but we had no choice. And so we did it right there. And Ravi was, of course, so obliging. He smiled through it all, smiled through the 2 days. And we had such a wonderful time learning from him. In that meeting, we also had Fred Ushakov, who had come in to handle some of the lectures with Ravi. And this is one of the product launches we had in that same meeting in 2017. And then that's that product launch meeting, and more smiles. And so we're very happy to see that, mingling with everybody as usual. And you can see that every single chair in that hall used to always be full. And the room was always full of even people who had general practice in obstetrics. And that was the main thing that we'd managed to hit. We were so happy that here we were in a situation where we were reaching out directly to people in general obstetrics, and they were able to tell us that, yes, we benefit from this information. We know exactly what to do with this information. And so it truly, truly worked out very well for us. And you can see Dr. Suresh sitting right there, Chandalula there, and a host of other people in the background. And then this was that famous talk about the intracranial translucency. It was fantastic. And he said, yes, 2009 was the article in the journal, in the White Journal, and then 2011 we were hearing him in person. Fantastic indeed. Always very kind to share everything with us. He even went on to sign all those certificates on behalf of ISWOG and put us in touch with ISWOG right in front. And, we've grown as sister organizations, if I may use the word, over the years. And we work together with ISWOG to bring a lot of our speakers to you. So with that, let me also mention that we've had the privilege of several presidents after that. After Professor I.C. Verma, we had Dr. Deepika Dekka, who came in as president, and then we had Dr. Ratnapuri, and I took over after that. And then, of course, very wisely, Dr. T.L.M. Praveen has come in and put all our systems into place. With him and Dr. Sunil Mehta, we've had a lot of our legal work sorted out. We've had our finances sorted out. Everything is right there. I won't bore you with more of this. I think we've all managed to find our little places. We have been able to divide you on Facebook as well as YouTube, because we knew that there would be an overload here. But this is really nice that so many of you have come together. And thank you, Ravi, for making this the first of our major events in our birthday celebrations. Thanks so much for being with us for the last so many years and for inspiring so very well. I now hand over the floor to Dr. T.L.M. Praveen to give a formal introduction, and then we're all waiting for your absolutely marvelous talk.
Yeah.
Praveen, over to you.
Good evening, Ashok, and good evening, everyone. And welcome, Ravi, for this birthday celebration.
Hi, Praveen. Good to see you.
Hi. Good to see you. And we are 10 years old, and we are still young. And you around, we feel much younger. And there is no need to introduce you, because SFM is part and parcel of Ravi is part and parcel of SFM. And as you are our honorary member, I think it's a great privilege to invite you. And it's an auspicious time that we are going to start this birthday celebrations. And the first event is going to be headed by you. And thank you. Please take over. And then I know you believe in simple things. And that's the reason why we choose this topic of simple science for complex syndromes. I think you'll make it much more simpler so that we simple people
I hope so.
Understand that. Thank you, Ravi.
Thanks, Praveen, and thanks, Ashok, for the nice introduction. I'm really honored and now really embarrassed by these nice words at the beginning. And do you hear me well? Yes. You hear me well?
Yes, we hear you well. The slides
okay, great.
Yes.
So, and it was a long time ago. So I remember when after this meeting, you went in the basement, you were sitting in a dark room together on a table, and then you discussed, and in the evening you told me, now we founded this society, and I will give you the dates until 2022. You have to come every year. And was coming almost, I think, at the beginning of May was the date. So I said, okay, and tried to one year to be off. I said, please let me 1 year not come. And then anyway, it was really nice time. And I enjoyed all the years being there with you. As you have noticed from the photos, it's not, let's say, not selected. This is reality. And I really appreciate people who want to learn, because this is the way I approach ultrasound. And let's say I had several teachers in my career, not let's say the one who taught me, but the one who inspired me. There were one group showing how good they are, like, I don't know, not sad names, but then there are a second group who tries to show you simple things to say, make it simple, and people will adapt this approach. Like Kipros, for example, the nuchal is by far the simplest screening tool in comparison to the difficult scores and so on. So again, thank you very much. But I don't know, Ashok, when you offered me you wrote a book on 3D gynecology. I don't remember. Was it in
2002?
Where were we there?
It was in 2002.
Yeah, but I don't know when you gave me this book. I said, I have the book of Qur'an, but I remember you. This is why when we went to
I gave
the
it
floods, went to Bangalore. I said, I know this guy. He's a great guy.
Yeah.
So anyway, so thank you very much. And so also for Praveen and for Ashok for the nice words. And ladies and gentlemen, so I was asked to speak on simple science for complex conditions. And this is what I will start with you now. So in the next 45 minutes, you know, this is quite simple, fetus with Down syndrome. And what you should keep in mind is how are we approaching syndromes? In general, we take books of genetics. And honestly, if you take a book of genetic and seek for Down syndrome, they will write for you the mongoloid eye and the typical features and but let's say signs like the absent nasal bone, which is very powerful, is not present there. So this is why we need, for example, or the ARZA was not existing for years. So this is why we need some signs, let's say, even from postnatal genetics, but many other adapted to fetal life. This is why any new syndromes or syndrome where the signs are published in utero can be helpful for many of us. This is why what I try to do is when I read literature or I see talks done by friends at meeting, I'll try to adapt what I'm seeing there. And this is why you should keep in your head a lot of syndromes. There are books you can look for, but you can also go and ask Google or PubMed, or in future it will be only all stored in artificial intelligence. I will speak one word at the end on this. So in comparison to 2021, if you see an agency of corpus callosum with the plexus cyst, is it automatically a transmit 18? No, because you have other signs of 18. Do you know what is the underlying cause? Or if you have cardiomyopathy here, what are you going to do with this fetus? This is why what I want you to learn today, some known signs, classical signs I will repeat, but some not so really unknown signs. And let's say I will, of course, show you only cases I could solve, because cases I cannot solve are not so nice. Now, I want at the beginning to share with you some concern. Some people nowadays think that ultrasound and fetal medicine works this way. You identify an anomaly, you take a sample of amniotic fluid, you give it to the genetics, and you say, please do karyotype RNA exome, and then you can rely and say, please give me one espresso, and you have no headache. But what I want you is to challenge. This is not the way I like. I want you to challenge as a specialist, and I want you at the end to be excellent fetal medicine. So in a way that you go to the geneticist, you tell him, please seek for this anomaly, because there are many signs. I think this is syndrome A. And they say, no, no way, because blah, blah, blah. And then at the end, you are right. But sometimes, of course, you are not. So this is why, as an inspiration, we don't put doctors. I will put these people, Sherlock and House MD and Colombo, because every one of these has this approach. And at the end of the day, I think our approach in utero when we scan a fetus is always a mixture of these. For example, the Dr. House, what you like it in his approach is he has a lot of knowledge. In general, you think, how comes that he knows so many things? This is why I would recommend you always to read articles and to be always up to date. And personally, I'm a little bit disappointed from the White Journal, because this used to be a journal where you have a lot of nice images of rare conditions where you could learn from, but because of the impact factor, they run now and they publish mainly, let's say, either studies, which is okay, or meta-analysis of thousands of data where you say, okay, but I want to see how ultrasound look like. So this is why, it's not as, for me, as useful as it used to be in the past, specifically for some rare conditions. I like the approach of Sherlock because when you do the scan, you are thinking of one thing, but you have also in mind some details, and the details at the end reveals the diagnosis. So this is where you say, oh, he's clever. This is why you should not focus on one aspect, but keep an overview. And as soon as you see something let's say, coping with another abnormality, switch and make a new combination of your information. And last but not least, I love Colombo when I was a child. This is the most the best episode I was looking at, because the questions he's asking at the end is always ultimative. So if you have the correct question to yourself or to the patient, you know exactly what's going on. So this is why I hope we will use this. And we have some typical hints for syndrome. They can be simple, like specific. If you see rhabdomyoma, you know what you're looking for. There are other syndromic conditions when you see a bone, a shortened bone. So you see, oh, it is skeletal dysplasia. And some expect from you to run, let's say, in your mind, 350 genes, which is not possible, but the most common can be easily done. And sometimes there are conditions like ventriculomegaly where you don't know really what you're looking for at the beginning, and then it is, let's say, tapping in the dark. So this is how I think we work. We have some signs, and once you see, this is the tractography of corpus callosum. And once you see a sign, you put it to the other side of the brain where you have collected numbers of syndrome. As you see, if you don't have it in mind, there is the OMIM, the Library of Congress, where you have the online Mendelian disorders, and this is where you can seek for the combination of findings, but in general, it's your brain. So this is why we combine known syndromes, or even syndrome you saw at meetings, or syndrome we read about, with some signs. And as soon as we see the sign, we try to combine. So let's start a few words on hard anomalies. We have the typical karyotype abnormalities, which 21, 18, 13, which is known. We have the microarray as the George and Williams-Boyron syndrome, typically, and we have the parallel exome like TSC, Charge, and Kabuki syndrome. But this is another talk. I will discuss this at another occasion, I hope. But let's say now, the tuberous sclerosis, Bourneville. Now, the condition is very common, 1 out of 6,000 births, which is, you can calculate, it's, let's say, could be as common as trisomy 13. But, it's easy to detect because you see the rhabdomyoma. But you have to keep in mind that 84% of the cases can be solved by molecular genetics, and of the TSC1 and TSC2 gene, which are involved in the mTOR pathways. But keep in mind also that 15 to 20% are inherited by one parent. So in other words, and this is one of my earliest cases here, April 94 on April 96, I wrote at that time multiple rhabdomyoma and tuberous sclerosis because it was likely, since the mother had epilepsy, and this was the first time. But at that time, there were two things. Since we have in the meantime genetic confirmation, which was started in the late 90s. We had at that time one lab who did it in Germany for 4 weeks time. And we know also that the brain lesions can be seen in utero. So this is why you see the different shape. You have one small, you have multiple fall, you have one large one. So, and this is why I told you before, if you have the knowledge, like the House MD, that some are inherited from one parent, what you do when you scan, this is my tip for you, turn on the light, what Sherlock says, and watch the patient carefully and ask them, do you have epilepsy, skin lesions, facial skin anomalies? Or you ask, do you have a brother or a mother having epilepsy? And they say, how do you know? My mother had epilepsy, but she's okay on the medications. And then you know that they may be affected. So these are 3 patients where I do this the same. I turn on the light on, and I saw this. This is the latest one I had. She came, she's an immigrant from Syria. She had epilepsy, and at 22 weeks, well, she came at 12 weeks because of the drug she's taking, and assume, well, it looks like medication and the risk of spina bifida, but was normal. At 20 weeks, I said, oh my God, how did I not notice that it could be tuberous sclerosis? And I asked her to remove the mask, and you see here, these are the lesions, and the fetus had a single rhabdomyoma, and then we knew that she has a mutation, and she confirmed, and the baby is delivered. So you see here, these are 3 cases. So think, when you see rhabdomyoma, of looking to the face and to the skin of the patients. Now, what do the brain findings look like? It's interesting because you should know not only that there are some findings, but you should know where to seek for. And you see here from one study called Tosca study, the rate of cortical tumor are 80%, and the subepidermal nodules are 80%. These are the most common ones. So what you should seek is in the peripheral part of the brain some large echogenic structures, and you should seek in the region of the here, exactly here, where you look at in the frontal view on the region of the foramen of Monro, you have the SEN, which can be found. So this is why it's easy, because you can compare left and right. And these are here. These are rare conditions, the SIGA, which are the giant astrocytoma in utero. So in other words, when you are seeking for the SEN, the heterotopia, you see it in the region of the foramen of Monro. And when they enlarge, they can lead to obstruction and to unilateral ventriculomegaly. And knowing this, and this is here a histology of a case, you can see that is exactly the typical lesion, and this is where I seek for them. So knowing where they are, then it's easy to go there and to scan. In the past, I was looking for anything in the brain, but in the meantime, we have enough data from postnatal MR, so we translate them into it. And the other part is that the so-called tubers in the cortex, where when the child dies or used to die in the past, they were like let's say, hard structures, and this is where Bournonville discovered that these are the tubers. And you see in the region where there are these echogenic, there is an abnormal gyration here. So this is only seen by vaginal ultrasound. You rarely see it abdominally. So take your time and see for it. And you see this fetus has both in the frontal view, but in the linear probe. I'll show you an example now. This is a fetus. I saw a rhabdomyoma. I don't see anything in the brain, nothing. 23 weeks of gestation. I told the lady, you know, these things appear a little bit later on. The same brain at 28-week gestation, you see the filling of many echogenic dots here. These are the whole tuber. And look at from the frontal view, you see in addition to the nodular heterotopia, you see the echogenicity. So take your time. 25 weeks, start by scanning the brain abdominally. I will start always at 22 weeks, but almost cases when they appeared after 6 weeks. And I feel it is better and more comfortable than MR. In MR, you hardly see the tuber, but you mainly see the SENs. You know his guy? This guy is, as you see in his hand, it's written here, number 22. This is Angelo Di Giorgio, and he described in the 60s a disease where there is a cardiac anomalies and thymus aplasia. In the meantime, it was called in the early 90s Catch-22, abbreviation for cardiac anomalies, abnormal facies, thymus hypoplasia, cleft palate, and so on. But it was abandoned since it is now too complicated, and it's not only summarizing these. So the typical images here are, you should focus on the kind of anomalies. So the anomalies typically are the interruption arc or the conotruncal anomalies like absent polyvalve syndrome or common arterial trunk, but rarely, but also possibly some VST or transposition of great arteries or malposition. So this is why the risk increases if you have an association with an ARSA or right aortic arc. But let's see, what we started working on in the mid-90s was the thymus. And Yaron Zara listening to us here today, and he also published an observation how the thymus looks normally in the year 2000, and this is where we started. I had done a collection of abnormal cases and abnormal cases, because with the high resolution, we were able to see that there's a difference between the lungs and the thymus here in the middle. And you see in these cases, they have all small or hypoplastic thymus, and some of these may have had, like it's not shown here, they may have also normal heart. So the abnormal thymus here is a typical sign, which is typically when it's absent. Sometimes in a small thymus, you may have conditions with the trisomy 21, but let's focus now on the 2211. And you see here it's a video where seeking for an abnormality of the great vessels, you are obliged anyway to look at the 3-vessel trachea view. Don't focus only on the great vessels, but only go and seek and check for the region between the vessels and the sternum. And this is what we defined as the thymic thoracic ratio. Another sign we published a couple of years ago by a really accidental observation is the dilated CSP after 22 weeks. And we found out that if you look at the normal values, we measure in the middle because the shape may be changing of the CSP. You see that after 50 millimeter, which is after 22 weeks of gestation, you have almost 90% having dilated CSP. So the CSP dilation is not specific because you find it in Downs, you find it in trisomy 18. But if you see a conotragal abnormality, you think the thymus is good looking, and you look at the head has a small CSP square shaped normal. So it's probably unlikely. If, however, you have vice versa, you scan the baby, you do the PPD, and the patient came referred because of a, let's say, of a cardiac anomaly. While you measure the PPD, you see, oh my God, it looks large. And then you look at the heart and you see the thymus. So you have the diagnosis within a few seconds. So this is something inexisting in postnatal studies because no one has, let's say, it is not written in books of genetics, I mean. Now let's move to the, you see these are also images of dilated CSP in 22.11. But sometimes I get the question, oh, if you've seen isolated CSP, is it going to be? Of course not, because you have 5% according to the reference range who are going anyway to be slightly dilated. So it's not so specific, but in combination with other increases the risk. Now let's move to the next group of skeletal anomalies. In general, the most two common one I want to discuss today. I cannot discuss all. It would be a special talk on skeletal anomalies are achondroplasia and tonotrophic dysplasia. They are the most common one. One is lethal. It is the tonotrophic dysplasia, and one is common. It's called achondroplasia later detection. So in one paper of Linchiti some years ago, she showed the size of the femur in relationship to the gestation age. And you see that the early cases, even from 15, 16 weeks, where the femur is very, very short, are tonotrophic dysplasia, where in achondroplasia, the size of the femur is almost normal until 25 weeks. And this is, in general, a late detection at after 25 weeks gestation. So this is why it's not so easy to use sometimes if you see the first time at 25 weeks, but it's okay. And the tonotrophic, they have small ribs. So, and let's start now with achondroplasia. You see some examples, even as you see in the upper left, we were in Egypt in the Egyptian museum, historic museum with Kypros some years ago, and I was lucky to ask him to stay there to make a photo. And you see, even in old Egypt, there were achondroplasia, and you see Picasso, and the young people know it from Game of Thrones today. So it is the most frequent non-lethal skeletal dysplasia with 1 to 20,000. This is the frontal bossing, but honestly, I could sell you this nice video as a normal fetus. But these hands are abnormal, and the short bone, long bones are short. So what is the trick I would show you, because it's detected in third trimester? There were 2 papers published on this field by a French group and retaken by Asma Khalil some years later. And look at now the shape of the femur. This is the femur, and we have the femur with diaphysis, metaphysis, and epiphysis. What we see here is the diaphysis. The metaphysis is the second part of it, and then the part which is not yet ossified is the region of the and the angle here to the between the metaphysis and the diaphysis. So if you draw, you see here the echogenicity. If you draw an angle here, the angle will be under normal conditions 100 to 115, so roughly. I'm not asking you to measure the angle, but look at now in fetuses with achondroplasia, you have here the metaphysis is larger with the angle. So look at now here this video of a normal case and abnormal case. Now, once you know it, I'm sure next time you are measuring a short, long bone, you will have a look to it more carefully, because you think, oh my God, is it going to be an achondroplasia? Because, you know, if you have short bones after 25 weeks gestation. In one of the meetings of Kypros, I was at breakfast with Asma Khalil, and we were discussing her sign, and she said, do you think that the values can be shorter even earlier? I said, why not to us? And we checked with several people, we put data together, And we went to the database of some centers, and we found out that achondroplasia cases, like here, 31 weeks, 28 weeks, 31 weeks, and so on, have this typical abnormality of the diaphysis. But if we ask the colleagues to send us the pictures they did at 20 weeks when they were doing the routine scan and the diagnosis was not known, we found out that these were also present earlier in gestation. So theoretically, if you have some, either you see it, or if you have some slightly short bones, you know, it is still in the range of normal, but head to femur is short, and you start thinking of down, and the lady had her NIPT, and you tell her, no, we need an invasive because I don't know. Think of looking to the femoral diaphysis metaphysis angle. If it's like this, think of condition could be achondroplasia. And this is a recent case I have followed since the beginning, because the father, the husband of the lady, had achondroplasia, and they did the CVS. It was confirmed, so I had a chance to follow up. And you see here, it started to be out of the range at 25 weeks gestation. And this is what I was telling you. The head is large, the long bones are short, but the ratio of head to femur started being abnormal at 18, 19 weeks. So this is where you should seek for this achondroplasia. Now we come to the second group, which is thanatophoric dysplasia. And you see the word Thanatos is the god of death in Greece. So these are obligatory death-going diseases. However, there is I saw in the meeting some studies saying that some can be treated, but this is only probably research. It is the second most frequent one, 1 to 30,000. And it's detected in the first semester, but generally second trimester. You have two types: type 1 with the typical abnormal bones with a normal head looking, and type 2 with the 10% of the group. It is the clover leaf skull with rather long bones straight. The typical, what you see here in thanatophoric dysplasia is the frontal bossing, of course, but typically you have very, very early short bones. You have short ribs, which is a sign of lung hypoplasia. You have the typical short hands, which is not so quite different if you compare with the hands of late gestation of achondroplasia, so not specific. This is why, how are we going to use new signs or other signs to know it is thanatophoric dysplasia? One of these is the size of the vertebra in comparison to the intervertebral space, what is called platyspondyly. And the second is the brain abnormality. So platyspondyly means, if you look at the spine carefully, and I hope if you have not seen this sign, next week when you are scanning, look at carefully to the spine, you see that the vertebral body are quite echogenic and large, and the intervertebral space is small. And you see on the X-ray, it is the normal X-ray and the abnormal one. And the intervertebral space is larger than the vertebral height. And this is here a normal case. And this is thanatophoric dysplasia with a linear probe, where you see that it's really small in comparison to the space. Best seen in the lumbar part of the fetus at 22 weeks. You see here, this is now, if you know the sign, you see, oh my God, of course. And this is why, do it simply when you have a fetus next time and you think it's this thanatophoric. Go and have a look to the spine, and you will see it. You may see also that the conus medullaris is very low, but this is let's say, seen in some other diseases. And I think there are some other skeletal anomalies with platyspondyly can be seen, but not so frequently and obvious as in thanatophoric dysplasia. Now we come to the second sign, which is the brain sign. The brain here were published in two papers, not very well known, from Glass in Trondheim and from the group here around the Phil Glantz in Toronto. And it is known from pathology specimen that fetuses having thanatophoric dysplasia, they have an early maturation of the brain with a lot of gyration. And you see these gyrations are so obvious, and you can see them very well. But in the meantime, we know that this is not typical for thanatophoric, but it's present in many FGFR mutation, the fibroblast growth factor mutation and receptor, and this is why keep it in mind. So this is why you see here at 22 weeks how it looks like. So when I saw this, I said, oh my God, it's true. I said, well, but if it's already so severe at 22 weeks, it should start earlier. It should not start at 20 weeks, probably earlier. And next time I had a case at 15 weeks, I saw the typical short bones and so on. And I saw for the platyspondyly, I could confirm it, because you see this is the normal spine and this is the platyspondyly. You see here how thing. And then I had a look at the brain. I saw already at 15 weeks polymicrogyria. And then I said the same. If I see it at 15 weeks, it should start at 12 weeks, 13 weeks. And Anstoy, in his paper on from Toronto, they put a case of 12 weeks. So, and then next time I had this is the 13 weeks fetus with short bones. I was watching here what's going on in the region of the brain. You see here the typical multiple gyration. And this is for me a simple sign. So you have, when you see some early disease of a bone, either you have osteogenesis imperfecta, but you don't have any bones here, only the occipital bone. So if you have less ossification, it's osteogenesis imperfecta, but you have thanatophoric dysplasia. Look at this gyration, and you have within few minutes diagnosis, but please scan vaginally because it's better to see it, and abdominally to have a look with a linear probe of the platyspondyly. And this is here the brain put in a spoon by the pathologist. They were surprised that I could see at 30 weeks in the fetus of 8 centimeters, the abnormal gyration. Now let's move to other brain anomalies and ventriculomegaly as a hint. And I want to show you a case, unusual. Fetus referred because of ventriculomegaly. And you saw the checklist we do is spina bifida, chromosomal anomalies, infection, agents, corpus callosum, hemorrhage, then the Walker, so posterior fossa anomalies, aqueduct stenosis, lissencephaly, and so on. The list is well known, but but life is not always like this. Life is sometimes different. So this is why you should be aware, as I told you, like Sherlock, to think out of the box. So I had the case here. This patient came to us, an Arabic patient. She wanted to be scanned first by a lady, which is okay. So my colleague was scanning her, and she said 10 millimeter, 11 millimeter. And she called me and told me, I have difficult scanning conditions here, and can you have a look? So I said, okay, looks like ventriculomegaly. And what do we have as additional things? And she showed, I had a look to the images. We have a normal profile, nasal bone. We have corpus callosum. We have posterior fossa with a normal size. And then I said, okay, let's go to the checklist. Have you seen the posterior fossa? She said, yes. Corpus callosum CSP, she said, okay. Sylvian Fisher was normal, as you see here. The face was normal. The heart looked normal, so it's not a combination. I said, "This is the boy or a girl?" And she said, "It's a boy." I said, Have you had a look to the thumb? It's adducted. That, yeah, I had difficulties on looking to the hands. And I said, "What do you think? What is your suggestion?" She think, there is one thing disturbing me is I don't have a quite nice view of the CSP because it looks like being in a shadow. And when she said shadow, I said, "Oh my God, shadow." Shadow, that stop. Shadow is a typical hint of craniosynostosis, and there could be also in macrocephaly. She told me, no, the size is normal, and these are the two papers showing the brain shadowing sign. You see here, there is a shadowing here. So I said, please, can I examine the lady? I asked her, I cannot guess here. I need to examine you. And I realized one thing. What is craniosynostosis? I told you that the temporal lobe dysplasia is typical for thanatophoric, but also in FGFR mutation. So I said, how are the bones? Because in the first moment I said thanatophoric, and then the bones are normal. And they said, okay, shadowing sign plus FGFR means there should be craniosynostosis with FGFR. What are the lists? Then you have in your brain few. You see, it looks like Cruzon syndrome or Apert syndrome, and these two. So I said, okay, let's have a look to Apert syndrome sign. And I remember I had read the title in the prenatal diagnosis of Apert syndrome, temporal lobe abnormalities in fluid imaging. At that time, I was smiling because I said, who cares in Apert syndrome to look at the brain, because it's so obvious, the face and the hands, but it's not true, because at that stage, the head shape was normal. So I took a look at the hand, and it was the typical mitten hands. And because, another view may have thought it could be the thumb and so on, but this is here Apert syndrome. Why? Because the combination of craniosynostosis not yet well developed, plus the FGFR sign revealed the disease. Later on, at the follow-up 27 weeks, then you had the typical signs with the high head, with an abnormal face, with the abnormal hands. Then you make the diagnosis. But at that stage, it was not so obvious the head shape. So this is why I try to tell you, think out of the box. Now we come to the next group, and we have here agenesis of corpus callosum as a disease. This is where, in general, we give up, because you say at least 70 syndromes. If you look at agenesis corpus callosum in OMIM, you have 1,600 entries, so no way to know all these things. And this is why you should at least know some few. And among the genetic array findings, you have the trisomy 8p, which may be common, but this is what we see. When you have agenesis corpus callosum, this specific case, you have dysplastic and you have abnormal vessel. What to tell the parents? I want you to know 3 diseases, 3 syndromes to know. One is a familiar one, another one is typical in girl, and one in boys. So when I see, this is why when I see an abnormality of the brain, I ask, well, is it a boy or a girl? So for girls, there is one disease called Icardi Syndrome. The problem in Icardi is that it has no gene yet detected, and it affects only girls. And we don't know the genetic background. So in general, it is a diagnosis of exclusion. You should have done array and exome and rule out anything else, but you still have the risk of having Icardi at the end. So, so this is why if you have an agenesis corpus callosum plus a female, look at the eyes, because the typical Icardi was first described with abnormalities of the eyes, but in the meantime, we know there are microphthalmia, there are some coloboma, but typically could be microphthalmia. And the typical hint is the presence of cyst, choroid plexus cyst, or interhemispheric cyst. You know, the interhemispheric cyst in combination with the agenesis corpus callosum plus a girl, I would always suggest to think of Icardi syndrome. And the cortex, because it can develop polymicrogyria, but extra cerebral, maybe the spine can show, let's say, absent ribs or hemivertebra. So let's take a case. So agenesis corpus callosum, like this one here, you see it's a girl, and you see that you have here plexus cyst, you have a control, and then you confirm. And yeah, this is here one case, and this case, the cysts were less in follow-up, but you see in this region, there is an interhemispheric cyst as well, and these bumps. We don't have genes, so this is why you should think of it. In this fetus here, there was a cyst in the brain, and it revealed to be interhemispheric cyst with agenesis corpus callosum. But look at these bumps here. The bumps here is typical, and this polymicrogyria in combination with the 3 other typical for Icardi syndrome. So this is here on MR. You see the bump. This one I have not seen, but the other one was typically seen. So you see the combination. Think of polymicrogyria of interhemispheric cyst in combination with agenesis of corpus callosum. And here, this is another case, the typical picture of both. So I did a dual photo, agenesis with a cyst, and looks like a girl, and the multiplanar mode shows the other features as well. So you have, at the end of the day, you will tell the parents, I don't know, I think it could be, but we cannot have, let's say, the true combination, or let's say the confirmation. And I had a patient, which is, let's say, a nice, sad story. She came and we had this diagnosis, and she said, okay, no problem. And she tried to find on Facebook, and she found a lady in London where the girl was three months old. And she asked her, you had a cyst and you have agenesis corpus callosum. Is the baby okay? She said, yes, okay. She said, my doctor told me here in Berlin that the risk of having seizures and epilepsy may be high because the disease can be Icardi. I never heard about it. No one told me. My child is healthy. So, and she had a scan. And a week later, she came and she said, I want termination. I said, what happened now? She said, the lady she was asking on Facebook wrote her that you are right. Yesterday night, my daughter had epilepsy, and we took her to the emergency room, and we're now starting treatment. She's at the hospital, and she said, oh my God, this is true. So you see that these social media may be for sometimes in our work. So, and you see, this is the video. Look at now the absence of the corpus callosum, the cyst, and so on. There is a paper submitted to the Wired Journal of 20 cases. I hope it will be accepted one of these days, and you will see the data of different centers collecting 20 cases. But We have, I showed you now several cases. Now, in other words, Sherlock will tell you if you see ACC, ask if it's a girl, and if it's a girl, check for the presence of any cyst in the brain, check for the presence of polymicrogyria, because the combination can be typical, and also for eyes anomalies. Of course, if you see eyes and brain, it could be also like ciliopathy, but in general, when you have ruled out other things, we still keep in mind it can be more severe. Not only girls, but boys may be also affected. And typically, what you know is hydrocephaly, but also agenesis corpus callosum. So many people do not know that ACC can be also the combination in the condition used to be called X-linked aqueduct stenosis, XLS. Today we call it L1 CAM or L1 syndrome. So, and I remember my earliest case was February 96. You see, I was very young at that time. And it was the typical hydrocephaly with adducted thumb. And at that time, we were sending probes to the Netherlands, to the one trying to find the gene to know. We know the genes, and this question of 10 days when you have the result. So this is why if you see the combination, it is called sometimes X-linked hydrocephaly, but also called CRASH for abbreviation of corpus callosum agenesis, retardation, adducted thumbs. The adducted thumbs is found in 75% of the cases. So next time you see the brain like this, you see it's a boy or girl. If it's a boy, go to the hands. If it's a girl, check for additional signs. And this is here, you see the thumb in these cases here. I'm hitting now that the baby changed the position of the hand, but it's staying in this case. And this is why I asked in the previous case, I showed you with the upper, my colleague, have you checked the hands if it's a boy and ventriculomegaly? Because this is the first thing I think of. A simple sign, but very powerful. And this postnatal in one of the children I've seen, and the ladies gave me this picture of the child. Now, this is why every time you have any brain anomaly with a male, check of the possibility of having L1 scam. It is more common than we assume to have 1 out of 15 to 20,000 cases, but also consider if you have a family history of a presence of a Fragile X syndrome. So let's say my geneticists say it's rarely to have a spontaneous case like this. This is why the typical history, they tell you, I have a brother, he had some birth damage, and because the delivery was so long and his brain damage because of birth, and my uncle, the brother of my mother, is mentally handicapped. You see, you have 2 boys where the ladies can inherit this condition. So think always on the possibility of having L1 scam. Now I come to, it was supposed to be my last case, but I will, if you give me time, I'll show you another one. So the ages of corpus callosum and what is called DCC, it is the third group. You may have occasionally parents having let's say, also an agenesis corpus callosum. Most of these do not know. No one will come to you and say, I have this disease, but they may have also one gene mutation. One of these groups is called DCC. DCC is a typical mutation where the prognosis can be also good because the penetrance may be also incomplete. So the baby, the father may not have, or the mother may not have Lotto's problem. It can be associated without internal disability, but they may have also typical signs. So this is why this is an abstract by a French group. They found that at the end, the presence of a DCC mutation improves the prognosis because you can tell the parents if this mutation, either one of you have it, but in general, the prognosis is not bad, is let's say good. And the shape, the DCC is abbreviation of deleted in colorectal cancer mutation. So this mutation is also found in another disease of colorectal cancer, but it is also associated with the corpus callosum agenesis. It is autosomal dominant, and it is involved in the guidance of access similar to the L1. So the penetrance can be either with no symptoms, or it can be only ACC, or it can be ACC without congenital mirror movements, or both. What is the congenital mirror movements? This is here when you have a person, when this person moves one hand, the other hand moves automatically without the chance of, let's say, that the person is able to manage this. So it is the intentional movement of the opposite side. So, and I had a patient, I asked her, this is the simple question, what you say, said, do you have problems in doing homework, at work at home? Said, I cannot cut any salad. And when I cannot work at home and things because my both hands are working the same, and I gave him a sheet of paper and said, please cut. Automatically, the second hand came together like this, like a scissor, and she's trying to cut. She's not able to touch, to hold the paper. And look at now the fingers, they do the same movement as this one. Look at now, see? This is why the simple sign is, I told her now, please try to hold the sheet of paper. She could not. Imagine she has 3 children, but could not hold it. The fetus had brain anomalies, is why it was easy to think of. But you know, for them it is normal. This is why they do not know how life is different. So, and this is the other way. You have what to tell the parents: move one hand and watch the other one. I said, move please the right hand, and automatically the other hand start moving with the same. This is here mirror movement. So it's really like Sherlock. You can give a task and you do something and you watch what is going on, and you know within 1 second what's going on. You see this fetus, you ask the mother and you do the amnio, and they reveal DCC, and you go to geneticist, and the lady told the geneticist, can you tell now my husband that I cannot do homework, I cannot do cell and so on, because I have now medical indication to avoid all the homework. Do I have time to finish with the actual case? I think yes.
Yes, sir.
Please go ahead.
Yes, sir. Please go ahead.
So this is the actual case because I, by chance, I found it. So I just was putting this afternoon for you. And this is a fetus I saw, you see here, August 21. She was referred because of polyhydramnio, macrosomia, macrocephaly as a female. So actually it was made diagnosed with polyhydram. You know, these cases, they call you, we have a polyhydramnio, it is never polyhydramnio. It was 4 afternoon. I said, okay, yeah, she can come and have a look. And I was really surprised. I was really shocked because I measured the head was out of range. I measured the abdomen, it is out of range. The fluid, I never saw with an amniotic fluid index of 40. So, and you see the shape between the thorax and the abdomen is large. It's a female because many of the macrocephaly or macrosomia diseases like Simpson-Gulabi-Damel are typical boy diagnoses. So, and then I thought for a second it could be Beckwith-Whitman, but the placenta is normal. The Beckwith-Whitman, they have typical mesenchymal dysplasia of the placenta, and they have really large kidneys, so all organs are large. So this is why it was more a large liver. So I assumed for a moment it could be some storage diseases. But why is the head large? And you see the shape of the head was also abnormal, large pericerebral space, but not so specific brain anomaly. Unfortunately, I do not have time to cover with you the possible differential diagnosis. And you see the nasal breathing to rule out coronal atresia as the reason. I saw the esophagus, and you see the amniotic fluid here. The third and the fourth quadrant were with an AFI of 40. So, and then I had a view to the face. Theoretically, I could tell you, I see the down-sliding palpebral fissure here, the low set of the ear. But you know, these things is when you are scanning, you say it looks like a coarse face, which is present in many abnormalities. And then I look at the heart, and for me, it appeared like a hypertrophic cardiomyopathy. So the thickened myocardium, and now you see large head, large baby, no hydrops, polyhydramnio, and hypertrophic cardiomyopathy. I thought on some of the rasopathies, Noonan syndrome group, but Noonan, they are never large, they are rather small. But we have had a case many years ago called Costello Syndrome. Costello, they have typically large head. It had prenatally only a large head, and postnatally 2 years later, it was diagnosed, and the lady came for a second pregnancy, and she told us that the large head was not because of the father, but because of Costello Syndrome. And I was watching the hand, and this is what I saw on the hand. Is it overlapping fingers? Not so really. And I did not like the hand for 1 second. And I remember at the last meeting, I was somewhere, and I was sitting with Benoit, and we're sharing experience. This is a case from Bernard Benoit. He told me, look at this fetus. I saw this. The neck was thickened, 3.3 millimeters. The carotid was normal. The CGH was normal, but maybe became too large head. Do you have seen fetus with large head? I said, yes, we had one. at the end, it was Costello syndrome. That it was Costello syndrome. And he said, how do you know? He said, the hand is typical like Costello. I said, what do you mean? He said, look at the hand here. And he told me, no, Costello, they have typical hand. It is even the symbol of the Society of Costello Syndrome. What is typical is what is called the ulnar deviation. And this is what he could see. And then said, my God, it's true. And when I was scanning, I thought, thank you, Bernard. This is exactly what I'm seeing here. I see could be Costello because of the ulnar deviation of the hand. And I compared to a normal hand, you see the ulnar deviation plus the large head plus the polyhedramnios. So I decided to write my report. I said macrozomic can be typical for conditions like metabolic disease, but also typical for Costello syndrome. And then geneticist said, you know, but Costello, they are small, they have small statures. That, you know, but check exome. So she had to be admitted to the hospital because she could not breathe. They had removed 3 liters of water and sent to our lab. And it turned to be, as expected, a Costello syndrome. And she came and said, you are great because you did the diagnosis. You know, it's only watching, observing, and said, you know, the hand was so typical. Said, what the hand? That, you know, the ulnar deviation is not so common, but it could have been something different. I will never show you if it would have been something different. So this is why keep in mind some complex anomalies may have simple syndromes, and the future probably will be again identify anomaly and ask artificial intelligence, put the data in a database. They will tell you the likely 2-3 diagnosis. You can perform amniocentesis and you will ask the intelligence, artificial intelligence, and then you will say not 1 coffee, but you say 1 volume, please, because then you notice that you are losing your job because AI may cover many of these things. So before I finish, I will advertise the next meeting. We are doing Katia Bilardo and Timmerman and Testa in Kiev online, and famous people like Ashok Khurana is speaking, like Yaron Zalel, and we have a session on syndromic conditions second trimester. I will be speaking on consanguinity. We have an afternoon only on first semester scan where Dr. Lakshmi from India will speak on the cleft. So it will be a fantastic program. And to my knowledge, from Monday on, it will be a little bit more expensive, but now it is for the 2 days, some €80, and you have 14 days access to this meeting. So register, and we'll see you there, all of you. And I thank you very much for attention, and also for your patience, and also for the honor given to me to present this presentation. And I wish you all the best and happy birthday, SFM India. Good luck.
Thank you. Thank you very much.
Thank you, sir. Thank you very much, sir.
Thank you very much. It was wonderful. And I think you are a mold of Columbus, Holmes, and Sherlock. I think you're put together an amazing talk and amazing presentation. And it's an eye-opener to all of us regarding simple approach to various syndromic conditions. Thank you once again.
Thank you very much, sir.
It was just mesmerizing, sir. And I think we didn't find normally any webinar, right? The moment the lecture starts, we start getting the questions on the chat box. There's not a single question which has come yet, because I think nobody wanted to get their eye or concentration away from the talk. They just wanted.
There are no questions. You don't need questions. No. But you know, I have to tell you one thing. Some years ago, after we finished the second edition of the third edition of the hard book, I discussed with Alfred, let us write a book on syndromes, all syndromes I've seen. And I said, okay, why not? And so on. And I started to put a table together, and I had 180 syndromes, 180. So let's see, if you see skeletal anomalies, you will run the 20 common one, and the heart anomalies, also the common one. So, and then he said, okay, if we spend 1 week each, we'll need 3 years. And after 3 years, there are new. So this is why we'll never finish. Don't do it. He said, okay, we stop doing it. So this is why. And I had started want to do a talk on syndromes from A to Z. I arrived to B and stopped because it was already 1 hour talk. Achondroplasia and Vertebral and so great. Thank you very much. Thank you for all, and thank you for your nice words. I see here a lot of blessing for the society, and
yes. And some of them confuse that it is your birthday.
Yes. But
I am SFM.
Yes.
Yeah,
You
fantastic.
are.
Thank you, Ravi. That
Thank you. Thank
is
you.
marvelous. SFM started because of you. We're continuing because of you, and we're so pleased you could do this special birthday event for us. We were joined by people from many countries tonight, and I'm so glad we made them all happy.
There is one question asking, is it prudent to attempt CVS in posterior placenta, or should we wait for amnio? I think there is always a way in almost all so-called posterior placenta to get there, because what you should do is you should take the probe and push the uterus a little bit more, to have the probe behind the uterus and push the uterus more anterior, or let the patient lie for 20 minutes on her belly. It rotates and then you can get it. So, but I will do the puncture, let's say, in the direction of not from up to down direction of legs, but down to up. So I go to the other side of the patient and you get it. So this is a trick. It's difficult to show. So if you are comfortable in doing CVS, you will do, even it's so-called posterior, you can get it. Don't believe me. Okay, everything was simple. Yeah, so great. What should I do now? Have a coffee or Valium?
There was another question on the size of the cavum septum pellucidum and its relationship to gestational age.
Yeah, it is. So I showed you. So 4 millimeters to 5 millimeters. But there's a reference range. You can have the paper there. So it's, you know, I will not exaggerate. In general, the cases are so obvious. So please do not start saying, oh, it's 5.1 instead of 5.0.
Would you like to go subjectively regarding the size, shape, and echogenicity of the cavum septum pellucidum, or more like an objective parameters?
Let's say I do not use it as main sign, as an additional sign. So this is why I will put it as a combination. The presence of a conotruncal anomaly in the combination of apparently small thymus and the slightly dilated CSP and so on, because you need always, when you write some things, to have let's say an escape door. So if you say this is a large CSP, could be a brain anomaly and so on, and the result come normal chromosome, and then he says, what is about the brain? So what the brain? The CSP. Forget the CSP. But you were writing, oh, brain CSPs. This is why what I try to teach, and I hope you will take it with you, there are true anomalies, there are hints. The true anomalies you exaggerate. True anomalies I exaggerate. The hints I write somewhere. So the true obvious finding, that fetus was polyhydramnio is obvious, large baby is obvious, cardiomyopathy was obvious. But let's say the fingers, the hand, I did not write it, because there is, oh, he will say it's crazy. So this is why.
There are two questions which have come in, sir, now. One was that, was there any tachycardia in the Costello case, sir?
Yes.
Costello.
In this case, no, but it's typical to have atrial tachycardia. But in this case, it was not.
And another question is, if there is a trisomy 18 with just rocker bottom foot and you know, the overlapping fingers, and there are no internal anomalies, do these babies do better?
I don't know, but I think it depends mainly on the growth retardation. If there is no growth retardation, it's really tricky to detect them. So I had a child, let's say a patient who came to see me because of one child having not been diagnosed with trisomy 18. It had no anomalies, it was normal, and until 30 weeks. And 30 weeks it was small, and it was delivered as trisomy 18, and they were having a nasal nutrition. But they will die then few months or years, but they can go into 1 year or 2 years. We had one child who developed liver tumor, and they wanted to have a transplant, and people say, hey, come on, we cannot give one liver to a trisomy 18 child anyway.
Yeah.
There's one more.
The window to many anomalies. Yes, it is the window for many anomalies. Yeah.
Any correlation between ventriculomegaly and skeletal dysplasias?
I showed you this one, but you know, almost, let's say, many with craniosynostosis, the group of craniosynostosis, they have often ventriculomegaly, and some of the skeletal dysplasia can be part of ciliopathies, Joubert syndrome, and they may have ventriculomegaly. But let's say not typical for, let's say, thanatophoric or for, let's say, diastrophic dysplasia. It's not the typical hint, but the combination would increase the risk, of course. Yeah.
I think one of these days you need to do a lecture on facial dysmorphism with various conditions.
I'm your man. Give me some months' time.
That is so kind of you.
I promise you, I'm there for the 20th anniversary.
Yes, thank you. Thank you. I'm so glad we have a 10-year extension to the contract.
Yes.
But this is, yeah.
One more question.
I can put together.
Yeah.
I'm preparing a talk on the face, but needs a lot of time. So,
sir, one more question which has cropped up just now. Recently saw a case with bilateral clenched fist and no other anomalies. What will be the prognosis and what to counsel if the karyotype turns out to be normal?
well, only clenched fist is unusual in general. If you have really like this, you should have abnormal feet. And the chromosomes are in general normal. But you will check here is the arthrogryposis multiplex congenita. And what I do in these cases, I look at the lungs, get a sagittal view of the lungs to see if the lungs are getting small, because they are often associated with the lung hypoplasia and polyhydramnios and so on. But like this, it could be very often a brain abnormality and not only doing by massage. So it's a bad sign.
Well, it seems like we're coming to the end of a wonderful evening, Ravi. Thank you so much for making it so successful. We have a few minutes from our trade partners before we shut tonight. And if I can have the messages from our trade partners, then and then after that, we will say good night. So just 2 minutes for our trade partners.
Established in 2012, LifeCell Diagnostics is a premier and leading comprehensive and convenient diagnostic services provider. LifeCell Diagnostics has a pan-India presence with a network spanning over 200 plus cities and 1,200 plus hospitals. A dedicated and expert team of over 400 paramedics and a 300-member sales force provide uninterrupted services to the customers. LifeCell Diagnostics offers an array of most advanced and biochemical, cytogenetic and genetic tests which have supported over 5 lakh mothers and 3 lakh newborns.
We have exceptional technical capabilities in the prenatal screening. We screen for aneuploidies and preeclampsia in the first and second trimester of the pregnancy at our labs located in Chennai, Pune, Manesar and Bangalore. All these labs are equipped with FMF recognized instruments and software that ensure accurate and high quality reporting. It is due to our world-class report technical expertise that over 5 lakh mothers have put their trust in LifeCell.
Thank you, Ravi. That is such a delightful message you sent to all of us, thanking us for the 10th year anniversary, but also that you will be so kind to do selfies with all of us. We really look forward to an on-site meeting in the coming year. And we promise you the first one we have, we would love to have you as a guest. I truly look forward to that. Today was an absolutely amazing talk. It's something I would love to have for breakfast every day, so I get inspired more and more. It is amazing how you have taught us over the years that everything can be simple. We don't have to have anything complicated. That is truly the essence of today's talk. We've come up with the biggest names and syndromes with the easiest way of identifying them. Thank you so much for making this evening so fabulous.
Thank you, Ashok. Thank you all. And thank you, Praveen. And thank you, Bimal. And
thank you.
I love you all. Bye-bye.
Thank you. Thank you very much.
Bye.
And with that, I also, thank you. And I encourage you to register for Ravi Chave's meeting on the 3rd and 4th of December. We will put it out again on the WhatsApp groups tomorrow morning so that you have an access to it. It's a virtual meeting and it's very, very reasonably priced. They've been kind to us as always with a discounted price. We also have this opportunity to thank our back end, Mr. Vishal Mittal in the office, who's always there for all of us at all times, and for Conferences International for being there with us to put all these webinars together. My thanks also to Lifecell and to GE for the constant support they give us. And of course, to each one of you who's made this great birthday party a huge success. And we look forward to celebrations throughout the year ahead. Thank you so much. And thanks, Bill.